Sodium channel blockers. Sodium channel blockade is the most common and best characterized mechanism of currently available anti-epileptic drugs, AEDs. AEDs that target sodium channels prevent the return of the channels to the active state by stabilizing the inactive form. In doing so, repetitive firing of the axons is prevented. Presynaptic and postsynaptic blockade of sodium channels of the axons causes stabilization of the neuronal membranes, blocks and prevents post-tetanic potentiation, limits the development of maximal seizure activity, and reduces the spread of seizures. 1. Carbamazepine. Carbamazepine, CBZ, is a major first-line AED for partial seizures and generalized tonic-clonic seizures. It is a tricyclic compound and initially was used primarily for the treatment of trigeminal neuralgia. Its value in the treatment of epilepsy was discovered quite by chance. CBZ's main mode of action is to block sodium channels during rapid, repetitive, sustained neuronal firing and to prevent post-tetanic potentiation. It has been approved in the United States for the treatment of epilepsy since 1974. However, it has been used for epilepsy since 1968. CBZ is a crystalline substance that is insoluble in water and thus is limited to oral administration. It is unstable and must be protected from hot or humid conditions, which decrease its bioavailability by 50%. Approximately 75 to 85% of the drug is plasma protein bound, and it has a free fraction of 20-24% of the total plasma concentration. Cerebrospinal fluid, CSF, levels range from 17% to 31%. It is metabolized extensively in the liver and induces its own metabolism. The major metabolic pathway is epoxidation to CBZ10, 11-epoxid and hydrolysis to CBZ10, 11-trans-dihydrodiol. Because CBZ induces its own metabolism, causing an increase in clearance and a decrease in levels, the serum half-life decreases by 50% during the first few weeks of treatment. The elimination half-life ranges from 5 to 26 hours following repeated treatment in healthy volunteers and patients with epilepsy. In children, the half-life ranges from 3 to 32 hours. Its induction of hepatic cytochrome P450 system activity also increases the metabolism of other AEDs. Peak levels of the drug are present in the blood for 4 to 8 hours. Formulations that are available include suspension, syrup, tablets, 100 milligrams, 200 milligrams, 400 milligrams, chewable tablets, 100 milligrams, 200 milligrams, extended release capsules, Tegretol XR, 100 milligrams, 200 milligrams, 400 milligrams, Carbatrol, 200 milligrams, 300 milligrams, and rectal suppositories. The extended release preparations, Tegretol XR, Novartis, and Carbatrol, Shire, are better tolerated than the immediate release preparations. CBZ is one of the most widely used AEDs in the world. It is highly effective for partial onset seizures, including cryptogenic and symptomatic partial seizures. It also has demonstrated good efficacy in the treatment of generalized tonic-clonic seizures. The drug is highly effective and well tolerated. Its major disadvantages are transient adverse dose-related effects at initiation of therapy and occasional toxicity. Potential dose-related adverse effects include dizziness, diplopia, nausea, ataxia, and blurred vision. Rare idiosyncratic adverse effects include aplastic anemia, agranulocytosis, thrombocytopenia, and Stevens-Johnson syndrome. Asymptomatic elevation of liver enzymes is observed commonly during the course of therapy in 5 to 10% of patients. Rarely, severe hepatotoxic effects can occur. Several drugs, such as macrolide antibiotics, e.g., erythromycin and clarithromycin, isoniazid, chloramphenicol, calcium channel blockers, cimetidine, and propoxyphene, withdrawn from the U.S. market, inhibit the hepatic enzyme cytochrome P4503A4, CYP3A4, which is responsible for the metabolic breakdown of CBZ, thereby raising its levels. Phenobarbital, PHB, phenytoin, PHT, felbamate, and primidone also lower CBZ levels through CYP3A4. Toxic symptoms or breakthrough seizures may occur if the dose of CBZ is not adjusted. Grapefruit juice in St. John's wort are inducers of CYP3A4 and can decrease CBZ levels. CBZ induces the metabolism of tricyclic antidepressants, oral contraceptives, cyclosporin A, and warfarin. Any drug that is metabolized by the hepatic enzyme CYP3A4 will have reduced levels because CBZ induces this enzyme. 2. Phenytoin. Since 1938, phenytoin, PHT, has been a major first-line AED in the treatment of partial and secondary generalized seizures in the United States. It blocks movements of ions through sodium channels during propagation of the action potential and thus blocks and prevents post-tetanic potentiation, limits development of maximal seizure activity, and reduces the spread of seizures. It also has an inhibiting effect on calcium channels and the sequestration of calcium ions in nerve terminals, thereby inhibiting voltage-dependent neurotransmission at the level of the synapse. In addition, PHT has an anti-epileptic effect on calmodulin and other secondary messenger systems, the mechanisms of which are unclear. The adverse effect profile, e.g., gingival hyperplasia and coarsening of the facial features in women, makes its use less desirable than CBZ in some patients. PHT is a lipid-soluble crystalline powder that is a weak acid and has a pKa in the range of 8.3, 9.2, which makes it soluble in alkaline solutions. Usually it is administered to patients as a sodium salt. It is not absorbed in the stomach because of the low pH of the gastric juices, but is absorbed rather slowly in the small intestines, the juices of which have a higher pH. Food and diseases of the small intestines alter PHT absorption. Oral bioavailability is approximately 95%, and peak level after oral administration is reached in approximately 4-12 hours. It is 70 to 95% bound to plasma protein, and the volume of distribution is 0.5, 0.8 L/Wg. The brain-plasma ratio is between 1 and 2. PHT is metabolized in the liver by the hepatic P450 mixed oxidase system and follows zero-order kinetics. A number of minor metabolites are formed, but none of them are active, i.e. they have no antiepileptic properties. Excretion is through the kidneys. Elimination half-life is 42 hours. The drug is available as capsules, 25 milligrams, 50 milligrams, 100 milligrams, 200 milligrams, chewable tablets, 50 milligrams, suspension, 30 mg 5 ml, 125 mg/5 ml, and injection, 250 mg 5 ml. Administration frequency is 1-2 times a day. PHT is one of the most commonly used first-line or adjunctive treatments for partial and generalized seizures, Lennox-Gastaut syndrome, status epilepticus, and childhood epileptic syndromes. It is not indicated for myoclonus and absence seizures. This drug is highly effective and economical for the patient. However, tolerability of the drug is still in dispute. One disadvantage of PHT is that it causes central nervous system, CNS, and systemic adverse effects. Long-term use of PHT has been associated with osteoporosis. Therefore, this agent must be used with caution in susceptible populations, and routine screening must be performed to detect the condition early. CNS effects occur particularly in the cerebellum and the vestibular system, causing ataxia and nystagmus. PHT is not a generalized CNS depressant. However, some degree of drowsiness and lethargy is present without progressing to hypnosis. Nausea and vomiting, rash, blood dyscrasias, headaches, vitamin K and folate deficiencies, loss of libido, hormonal dysfunction, and bone marrow hypoplasia are among the most common adverse effects. When given during pregnancy, PHT, like other AEDs, can cause cleft palate, cleft lip, congenital heart disease, slowed growth rate, and mental deficiency in the offspring. Among all AEDs, PHT has one of the most problematic drug interaction profiles. The two major reasons are its highly protein-bound, 90% nature, and its use of the P450 enzymes for metabolism. CBZ and PHB have variable and unpredictable effects, i.e., increase or decrease, on PHT levels, in that they both induce and compete for hepatic enzymes. Valproate VPA raises levels of PHT by displacing PHT from its protein binding site and inhibiting its metabolism. Other drugs that significantly increase PHT levels are isoniazid, chimetidine, chloramphenicol, dicumarol, and sulfonamides. Drugs that lower PHT levels are vigabatrin, VGB, and amiodarone. PHT itself is a strong inducer of hepatic enzymes and alters levels of other drugs. It decreases levels of CBZ, ethosuximide, felbamate, primidone, tiagabine, TGB, and PHB. It inhibits decumarol, warfarin, and corticosteroids. Clotting factors and immunosuppression must be monitored and doses adjusted accordingly. Other drugs whose levels are reduced by PHT and require monitoring and adjustment include furosemide, cyclosporin, folate, and praziquantel. Levels of chloramphenicol and quinidine are elevated by PHT. Because of PHT's poor adverse effect profile, epileptologists generally try to avoid prescribing it. Despite the difficult pharmacokinetics and the adverse effects, this drug is still used widely. The once-daily dosing, the good efficacy, the extensive experience amassed, the possibility of monitoring the plasma levels, and the availability of a parenteral preparation make PHT suitable for use by the primary care physician. 3. Fosphenytoin. Fosphenytoin sodium is a prodrug intended for parenteral administration. Its active metabolite is PHT. It is safer and better tolerated than PHT and can be infused 3 times faster than intravenous IV PHT can. When administered by IV infusion, maximum plasma fosphenytoin concentration is achieved at the end of the infusion. Fosphenytoin is completely bioavailable after intramuscular IM administration. Peak concentration occurs at 30 minutes after administration. The half-life is 15 minutes, and the drug is presumed to be metabolized completely by phosphatases to PHT. Fosphenytoin is not excreted in the urine. The antiepileptic effect of fosphenytoin is attributable to its active metabolite, PHT. It is clearly better tolerated than PHT. One double-blind controlled study compared the infusion tolerance of fosphenytoin at 150 milligrams per minute and PHT 50 milligrams per minute. Local intolerance was reported in 9% of patients after fosphenytoin loading, 21% had infusion disrupted, and the infusion time was 13 minutes. In patients who received PHT, on the other hand, local intolerance was reported in 90%, 67% had infusion disrupted, and infusion time averaged 44 minutes. Fosphenytoin is indicated for treatment of status epilepticus and for short-term parenteral administration when other routes are not available or inappropriate. Cardiovascular depression and hypotension may occur with fosphenytoin, but to a lesser extent than with PHT. These adverse effects usually are related to the rate of infusion. Slower infusion is recommended in susceptible patients. Severe burning, itching, and/or paresthesia, mainly in the groin area, have been associated with rapid infusion. The discomfort may be improved by lowering the infusion rate or temporary discontinuation. Hepatic or hemopoietic adverse reactions, like those seen with PHT, also may occur. Fosphenytoin is a better IV preparation than PHT, mainly because of tolerability and safety. It also may allow faster achievement of therapeutic serum PHT levels. However, fosphenytoin is much more expensive than PHT. 4. Oxcarbazepine. Oxcarbazepine, OXC, is a recently developed analog of CBZ. It was developed in an attempt to maintain the benefits of CBZ while avoiding its autoinduction and drug interaction properties. Licensed in over 50 countries, including the United States, OXC now is considered a first-line therapy in some countries. 9, 10, 11, 12. OXC does not produce the epoxide metabolite, which is largely responsible for the adverse effects reported with CBZ. Like CBZ, OXC blocks the neuronal sodium channel during sustained rapid repetitive firing. OXC is absorbed almost completely on oral administration and can be taken with food. It is metabolized to the active 10-monohydroxy metabolite, MHD, 10,11-dihydro-10, hydroxy 5-H, dibenz B, F, azepine, 5-carboxamide. MHD is the active compound that is responsible for the pharmacologic effects of OXC. Volume of distribution is 0.3, 0.8 OL-COG. Protein binding is 38%. The drug readily crosses the blood-brain barrier. Metabolism takes place in the liver. No epoxide is formed, accounting for the better tolerability of this drug than of CBZ. It induces some cytochrome P450 enzymes, including CYP3A4, CYP3A5, and CYP2C19. But other cytochrome enzymes appear to be unaffected. Excretion is via the kidneys. Peak levels are reached in 4 hours. The half-life is 8-10 hours. OXC interacts with oral contraceptives, thereby reducing their efficacy. It does not increase the metabolism of warfarin, ximidine, erythromycin, verapamil, or dextropropoxyphene. OXC is approved for monotherapy or adjunctive therapy in patients with partial and secondary generalized seizures. It is an effective drug for partial seizures, but may aggravate myoclonic or absent seizures. 4 randomized double-blind trials of this agent as monotherapy demonstrated effectiveness superior to that of placebo in patients with refractory epilepsy and in candidates for epilepsy surgery. OXC is better tolerated and has fewer drug interactions than CBZ. Retrospective studies have reported worsening of seizures caused by oxcarbazepine in juvenile idiopathic generalized epilepsies. Substitution for CBZ can be made abruptly with an OXC to CBZ ratio of 300-200. Comparison studies of tolerability between slow-release CBZ and OXC are not available. Available formulations are tablets, 150 milligrams, 300 milligrams, 600 milligrams, and the recommended frequency of administration is twice a day. The initial dose in children is 10 mg/kg/d, with titration up to a maximum of 30 milligrams per kilogram. In adults, the dose is 600 mg/d up to a maximum of 2400 mg/d. Some patients require low starting doses, 300 mg/d, and slower titration for better tolerability. Somnolence, headache, dizziness, rash, hyponatremia, weight gain, gastrointestinal GI disturbances, and alopecia are the most commonly reported adverse effects. The allergic rash is similar to the one caused by CBZ. Dose-related adverse effects include fatigue, headache, dizziness, and ataxia. Hyponatremia is mild and can be corrected by fluid restriction. Hyponatremia is uncommon in children younger than 17 years, but it occurs in 2.5% of adults and 7.4% of the elderly. Idiosyncratic reactions appear to be less common than with CBZ. 5. Eslicarbazepine. Eslicarbazepine acetate, Aptiom, is a prodrug that is activated to eslicarbazepine, the major active metabolite of oxcarbazepine. It is indicated as either adjunctive treatment or monotherapy for partial onset seizures in adults and children 4 years and older. The initial adult dose is 400 milligrams PO once daily for 1 week, then increased to 800 milligrams PO once daily, the recommended maintenance dose. Some patients may benefit from 1,200 mg/day maximum dose. An increase to 1,200 mg/day should only be initiated after patients tolerate 800 mg/day for 1 week. For some patients, treatment may be initiated at 800 mg if the need for additional seizure reduction outweighs an increased risk of adverse reactions during initiation. It may be administered with or without food. An increased dose may be needed if co-administered with CYP enzyme-inducing AEDs, e.g. carbamazepine, phenytoin, phenobarbital, primidone. Dosage reduction is recommended with moderate to severe renal impairment, 200 mg/day initially for 2 weeks, then increased to 400 mg/day. In September 2017, FDA expanded indication for eslicarbazepine acetate, Aptiom, to include the treatment of partial onset seizures, POS, in children and adolescents aged 417 years. The expanded approval for eslicarbazepine acetate was based on the FDA guidance that allows data extrapolation to support pediatric use. The efficacy and safety of monotherapy and adjunct therapy for adults with POS was previously established in 5 multi-center, randomized controlled studies. This data also supported safety and tolerability of eslicarbazepine acetate for the treatment of pediatric patients with POS. Common adverse effects, itawi on 10%, include dizziness, somnolence, nausea, headache, and diplopia. 6. Lamotrigine. Lamotrigine, LTG, is a triazine compound that is chemically unrelated to any of the other AEDs. It was developed as an antifolate agent on the basis of a theory that the mechanism of some AEDs is related to their antifolate property. LTG was approved in the United States in 1994, 13, 14, 15. LTG's major mechanism of action is blocking voltage-dependent sodium channel conductance. It has been found to inhibit depolarization of the glutaminergic presynaptic membrane, thus inhibiting release of glutamate. It has a weak antifolate effect that is unrelated to its anti-seizure efficacy. On oral administration, LTG has a bioavailability close to 100%, reaching peak levels within 1 to 3 hours and achieving a volume of distribution of 0.9, 1.3 L/kg. Its solubility is poor in both ethanol and water. Therefore, it is not available in parenteral form. Protein binding is 55%, and the elimination half-life is 41 hours. It is metabolized by the liver and excreted through the kidneys. It produces autoinduction at higher doses and has no active metabolites. LTG levels increase with concomitant use of valproate, VPA, to 70 hours. Combination therapy with VPA enhances the antiepileptic effect. However, it also increases the chances of developing allergic skin reactions. LTG does not induce or inhibit hepatic enzymes. Therefore, it does not affect the metabolism of lipid-soluble drugs, such as warfarin and oral contraceptives. Conversely, drugs that induce hepatic enzymes may reduce the half-life of LTG from 23 hours to 16 hours. LTG levels must be adjusted accordingly. LTG's significant effect on seizures was demonstrated in 9 of 10 placebo-controlled trials in which LTG was administered as add-on therapy. LTG resulted in a 17 to 59% reduction in seizures, with most trials showing 25 to 30% median reduction in seizures. LTG is effective in partial onset and secondarily generalized tonic-clonic seizures, primary generalized seizures, i.e., absence seizures and primary generalized tonic-clonic seizures, atypical absence seizures, tonic-atonic seizures, and Lennox-Gastaut syndrome. It is sometimes effective for myoclonic seizures, but can cause worsening of myoclonic seizures in some patients with juvenile myoclonic epilepsy or myoclonic epilepsy of infancy. LTG currently is approved in the United States for adjunctive therapy for partial onset and secondarily generalized tonic-clonic seizures, crossover to monotherapy, and Lennox-Gastaut syndrome. The dose regimen and titration schedule depends on co-administration of other AEDs, the titration rate being slower with enzyme-inhibiting AEDs, such as valproate, than with enzyme-inhibiting AEDs, such as PHT and CBZ. Preset packages are available with the recommended doses of LTG with and without VPA. In children on VPA, the starting dose of LTG is 0.15 milligrams per kilogram, with increments every 2 weeks up to a maximum of 1 to 5 milligrams per kilogram. In patients taking concomitant enzyme inducers, the starting dose is 0.6 milligrams per kilogram, up to a maximum of 5 to 15 milligrams per kilogram. LTG is available in tablets, 25 milligrams, 50 milligrams, 100 milligrams, 150 milligrams, and 200 milligrams, and chewable tablets, 5 milligrams, 25 milligrams, and 100 milligrams. It is administered twice a day. Unlike most AEDs, LTG produces few CNS side effects. Rash is the main concern associated with this drug. It occurs in 5% of patients and is associated with rapid titration. Severe rash, more common in children taking VPA, may develop and lead to Stevens-Johnson syndrome, which may be fatal, though this is rare, with an incidence of only 0.1%. Other commonly reported adverse reactions are headache, blood dyscrasias, ataxia, diplopia, GI disturbance, psychosis, tremor, hypersensitivity reactions, somnolence, and insomnia. LTG is the only AED with more than 500 documented pregnancy exposures. The International Lamotrigine Pregnancy Registry update reported 414 monotherapy exposures, giving a risk of 2.9%. The North American AED Pregnancy Registry found no overall risk of major malformations in 684 infants exposed to LTG monotherapy, but noted an increased risk of orofacial clefts. In contrast, the EuroCat Congenital Anomaly Registers did not find an increased risk of orofacial clefts for 40 children exposed to LTG monotherapy. The excellent side effect profile and lack of significant CNS toxicity make this drug one of the preferred choices in treating elderly patients. The reported low incidence of congenital malformations when exposed to pregnant patients makes this drug one of the preferred treatments during pregnancy. 7. Zonisamide, zonisamide, ZNS, was synthesized as a benzoxazole in 1974. It is chemically unrelated to any of the other AEDs. It is a small ring structure related to sulfonamide antibiotics with pH-dependent solubility in water. The major mechanism of action of ZNS is reduction of neuronal repetitive firing by blocking sodium channels and preventing neurotransmitter release. It also exerts influence on T-type calcium channels and prevents influx of calcium. In addition, ZNS exhibits neuroprotective effects through free radical scavenging. When administered orally, ZNS is absorbed quickly and completely, reaching peak levels in 2-4 hours. It has a relatively long half-life of 60 hours. It has a high affinity for binding to red blood cells, RBCs, and a 40% protein binding capacity, exhibiting a linear dose plasma concentration at doses of 100 to 400 milligrams. Partially metabolized by the liver, 70%, ZNS uses the cytochrome P450 system, which is followed by glucuronidation. Although it uses the cytochrome P450 system, it is not an inducer of the system. Metabolites of ZNS are not biologically active, and 35% of the drug is excreted unchanged in the urine. ZNS has been approved by the U.S. Food and Drug Administration, FDA, as adjunctive therapy for patients with partial seizures who are 12 years or older. It is preferred clinically because of the ease of patient tolerance, degree of seizure reduction, long half-life, and lack of drug interactions with other AEDs. ZNS provides dose-dependent, effective, and generally well-tolerated adjunctive therapy in patients with partial seizures. Retrospective studies have shown that ZNS is a very effective treatment for myoclonus, especially in juvenile myoclonic epilepsy. In small series of women of childbearing years, spontaneous abortions, and congenital abnormalities in human fetuses have been reported at a rate of 7%, which is more than twice the rate in the general population, 2-3%. However, many of these women were treated with polytherapy. The most commonly reported adverse reactions to ZNS are dizziness, anorexia, headache, ataxia, confusion, speech abnormalities, mental slowing, irritability, tremor, and weight gain. Gradual titration of the drug appears to reduce the manifestations of adverse reactions. Somnolence and fatigue have been reported frequently. ZNS is associated with renal stones in 1.5% of patients. Therefore, the risk in patients with a history of renal stones must be weighed against the therapeutic benefits of the medication. Oligohydrosis has been reported in children, mainly as a result of the effect on carbonic anhydrase. Idiosyncratic skin reactions, e.g., Stevens-Johnson syndrome, toxic epidermal necrolysis, have been reported in Japan at a rate of 46 per million patient years of exposure. ZNS should not be used in patients who are allergic to sulfonamides. PHT, CBZ, PHB, and VPA decrease the half-life from 63 hours to 46 hours, thereby reducing levels of ZNS. However, ZNS does not affect the levels of these drugs. ZNS is a good alternative for patients with compliance problems because of its long half-life. It can be used once daily without significant fluctuation of blood levels. In addition, it does not have the cosmetic and pharmacokinetic problems of PHT. Its mechanism of action inhibiting thalamic T-calcium currents may make it effective in absence epilepsy and juvenile myoclonic epilepsy. 8. Lacosamide. Lacosamide, formerly known as urlosamide, harcosuride, or SPM 927, is an amino acid derivative referred to as functionalized amino acid. The OR in on-tiomer lacosamide has about twice the potency of the racemic mixture. Lacosamide is inactive against clonic seizures induced by bicuculin and picrotoxin, but showed efficacy against hippocampal kindled seizures at least as much as other AEDs, including phenytoin, carbamazepine, and valproate. Lacosamide was approved in the United States in 2008. Lacosamide has a novel mechanism of action of modulation of voltage-gated sodium channels by selective enhancement of slow inactivation, but without apparent interaction with fast inactivation gating. This effect may be relatively selective for neurons involved in a seizure activity, in which the persistence of sodium currents is more pronounced, and preserve the function of a relative less active neurons. Lacosamide does not affect AMPA, kainate, NMDA, GABA, GABAB, or various dopaminergic, serotoninergic, adrenergic, muscarinic, or cannabinoid receptors, and does not block potassium or calcium currents. Upon oral administration, lacosamide has a bioavailability close to 100% and is not affected by food. Intravenous infusion of lacosamide has demonstrated bioequivalence with the same dose of oral administration. Peak plasma levels occur approximately 4 hours after the dose, and elimination half-life is approximately 13 hours. Lacosamide has minimal protein binding, 15%, and does not act as an inducer or inhibitor of the cytochrome P450, CYP450, isoenzymes, and does not have a significant interaction with other AEDs. Lacosamide effect on seizures was demonstrated as adjunctive therapy in partial onset seizures in 3 12-week, randomized, double-blind, placebo-controlled multi-center trials in adult patients. Lacosamide has been used in children with refractory epilepsy of different etiologies and in adults juvenile myoclonic epilepsy with apparently good tolerability and fair efficacy, but controlled studies confirming the findings are lacking. Lacosamide has been used as well in patients in a critical care setting with non-convulsive status epilepticus, given the favorable pharmacokinetics and intravenous route access. However, the safety and efficacy of lacosamide in these situations has not been determined yet. Lacosamide currently is approved in the United States as monotherapy and as adjunctive therapy for adults and adolescents aged 17 years or older with partial onset seizures. The dose regimen and titration is based on clinical response and tolerability. The starting dose for adjunctive therapy is 50 milligrams BID and then increased by weekly increments of 50 milligrams BID up to 100 to 200 milligrams BID. The starting dose for monotherapy is 100 milligrams BID initially, then increased at weekly intervals by 50 milligrams BID up to 150 to 200 milligrams BID. Alternatively, a 200 milligrams loading dose may be given, followed 12 hours later by 100 milligrams BID for 1 week, and then gradually increased at weekly intervals by 50 milligrams BID up to 150 to 200 milligrams BID. Commonly reported adverse reactions include dizziness, headache, nausea, and diplopia. Lacosamide has been labeled pregnancy category C because it has produced developmental toxicity, increased embryo-fetal and perinatal mortality, growth deficit, in rats following administration during pregnancy. No human data is currently available. However, a pregnancy registry is ongoing. The excellent pharmacokinetic profile and relative good tolerability make this drug easy to use as add-on therapy. It is not approved as initial monotherapy in the United States. Intravenous formulation makes this drug particularly useful in ICU settings. The efficacy of lacosamide in status epilepticus has not been determined. 9. Cenobamate. Cenobamate was approved by the FDA in November 2019 for adults with partial onset seizures as either monotherapy or adjunctive therapy. The precise mechanism, if unknown, but it has shown to reduce repetitive neuronal firing by inhibiting voltage-gated sodium currents. It is also a positive allosteric modulator of GABA-A ion channel. Cenobamate was evaluated in patients with uncontrolled focal, partial onset epilepsy. The clinical trial program included over 1,900 patients. Adjunctive treatment with cenobamate was found to significantly decrease seizure frequency in 2 well-controlled studies. However, cases of drug reaction with eosinophilia and systemic symptoms, DRESS syndrome, were reported in early clinical development among the first patients exposed to the drug. In December 2018, results from a large Phase 3 safety study showed that among the 1037 patients exposed to cenobamate, no cases of DRESS were identified. Reducing the starting dose and slowing titration rate appeared to reduce the risk. Result from a multi-center, double-blind, randomized, placebo-controlled study, Study 013, at 107 epilepsy and neurology centers in 16 countries was conducted. The dose-response study included a 6-week titration phase, followed by a 6-week maintenance phase. A statistically significant 56% reduction in median seizure frequency was seen with cenobamate 200 mg day N = 113, compared with a 22% reduction with placebo, N = 108. In Study 017, which included a 6-week titration phase followed by a 12-week maintenance phase, patients randomized to Xcopri 100 mg day, N = 108, 200 mg day, N = 109, or 400 mg day, N = 111, had statistically significant 36%, 55%, and 55% reductions in median seizure frequency, respectively, compared with a 24% reduction with placebo, N = 106. During the maintenance phase, a post-hoc analysis showed that 28% of patients receiving Xcopri had 0 seizures, compared with 9% of placebo patients. During the maintenance phase of another study, Study 017, 4% of patients in the cenobamate 100 mg day group, 11% of patients in the cenobamate 200 mg day group, 21% of patients in the cenobamate 400 mg day group, and 1% of patients in the placebo group reported 0 seizures. Thanks for listening, and please listen to Part 3. Dr. Hamza Alsayouf, child neurologist, American Board, Amman, Jordan.